Today we're going to cover Chapter 10, Respiration and Artificial Ventilation. As we go through this chapter, really start to understand the difference between respiration, ventilation, and how this is going to affect the overall status of your patient. So here we're going to talk just a little bit more, reviewing the physiology and pathophysiology of the respiratory system. We're going to talk about respiration and what that truly means. Here we're also going to discuss with you the positive pressure ventilation and oxygen therapies that are available, how we can deliver those, and when we should be choosing each adjunct. There are some special considerations, but we do want to cover how we assist other EMS professionals with advanced airway devices. Because as we talk about intermediates and paramedics, it's important to understand that they have a different scope of practice, and therefore they do have some tools that we do not have to assist our patients. So it is important to note that ventilation is the movement of air in and out of the lungs. So inhalation and exhalation. When we talk about assessment, we talk about respirations, we're really saying how many times a minute are they ventilating. Now, inhalation is an active process. This is where the muscles are engaged, diaphragm is engaged, and the diaphragm contracts, pushing itself down. This allows the chest to increase in size and draw air into the lungs because of this negative pressure that is in the thoracic cavity. Exhalation is a passive phase, or basically a resting phase. The chest muscles and the diaphragm relax. This decreases the size of the chest, and that then forces the air out of the lungs through positive pressure. A couple of things that you need to know. One is tidal volume, and this is the amount of air moved in and out in one breath. So if I breathe in and I breathe out, that amount of air is measured. That is your tidal volume. Minute volume takes into account the amount of air that is moved in and out in 1 minute. So if you took your tidal volume and you multiplied it by the number of respirations, or truly ventilations, you would have your minute volume. In previous chapters, we've talked about the makeup of the lungs, and we've talked about gas exchange. So ventilation is designed to move the air in and out of the alveoli, and the alveoli is where gas exchange actually occurs. So this is where we get onloading of oxygen, offloading of carbon dioxide. But not all of the air that we breathe in actually reaches the alveoli. Some of this is in what we call dead space. Now, if you look at the picture on page 240 in your textbook, it kind of gives you an image. And it shows you the lung tissue that surrounds all of the lung structures, including the alveoli and all of the bronchioles. It's important to note that the air that is in the bronchioles and the trachea are actually dead space. This air does not go through gas exchange. Alveolar ventilation refers to the amount of air that actually reaches the alveoli in which gas exchange can occur. It can be changed based off of different things with your patient. It can be changed on the rate or the volume in which they are breathing and the air that they are taking in. It depends on that tidal volume and how much air movement is really occurring. There are some respiratory conditions that can inhibit air movement, and we're going to discuss those a little bit later. So recall, the alveoli are at the end of the bronchioles. They look like little sacks of grapes, and that is where gas exchange is going to occur. Now the pulmonary capillaries bring blood close to these sacs. Remember, they encompass these sacs so that the gas exchange can occur. And these capillaries are really small. They are 1 cell wide, so the red blood cells in that are having to pass through these areas kind of one at a time to help it be more efficient. Thin alveoli and capillary walls allow for this gas exchange, and again, it's oxygen getting into the blood, attaching to the hemoglobin molecule, and the carbon dioxide or our waste products are then moving into the alveoli so we can exhale them. So respiration is actually a process called diffusion. And if you ever learned about diffusion in chemistry or any of your other science classes, you know that diffusion is the movement of substance from high concentration to low concentration. And so when we're talking about substances here, we're dealing with the gases of oxygen and carbon dioxide. So we know that when we breathe air in, we've got a higher concentration of oxygen in the alveoli. It's then going to cross that capillary wall, trying to equal out the concentration, if you will, through that process of diffusion. Now, cellular respiration is diffusion of oxygen and carbon dioxide. This is going to take place between the cells and the circulating blood. So pulmonary respiration is taking place in the lungs with the alveoli. Cellular respiration is taking place out in the body across all areas where the capillaries are offloading the oxygen and onloading carbon dioxide to get it back to the lungs. So as we look at this process, we've got to have air moving in and out. We've got to have blood circulating. And so we've got to have this cardiopulmonary system, basically the cardiac system and pulmonary system working together. This may be called the ventilation perfusion match or VQ match. If we have an issue with either the respiratory or the cardiac system, then we're going to have difficulties in oxygenating the body. So, for example, mechanical failures are when we actually have a physical means of causing problems with the cardiopulmonary system. Something like a stab wound or penetrating wound to the chest is going to disrupt that negative pressure. And so again, when the diaphragm contracts and pulls downward, instead of drawing air into the lungs, this penetrating wound may draw air in through that opening. If we have a loss of nerve control, this also causes disruption with our ability to control the diaphragm and those intercostal muscles that help us with breathing. Painful chest wall injuries will sometimes limit chest movement because if it hurts, the patient is unlikely to do it. For example, if they have an injury to the chest, they're not going to breathe as deeply, and that is going to limit the amount of air that is drawn into the lungs. And things like bronchoconstriction or an asthma attack. This causes narrowing of the bronchioles, limiting the amount of air that's drawn into the lungs as well. Other issues that may disrupt this cardiopulmonary system are things like the percentage of oxygen in the air that we are breathing. So if we don't have the adequate amount of oxygen in the air that we are breathing, then we're not going to have the adequate amount of oxygen reaching the alveoli either. At sea level, oxygen takes up about 21% of the air around us. Diffusion problems caused by alveoli that do not work also can be problematic in that cardiopulmonary system. Sometimes conditions like COPD will cause the alveoli themselves not to function properly. And if the alveoli are not functioning, again, gas exchange is not going to occur correctly. So as I said, if there's an issue with the respiratory system or with the cardiac system, we're going to have problems. We reviewed some of the pulmonary issues, but what about cardiac? When we talk about circulation, we know that the oxygen is going to be carried by the red blood cells, and that's going to travel through the vascular space with every heartbeat. So if we don't have the correct amount of red blood cells due to some type of injury where we've had blood loss, then we're not going to have enough red blood cells to transport that oxygen to the body. So insufficient hemoglobin also can be caused by conditions like anemia. And if we don't have enough hemoglobin, or if there's a problem with that hemoglobin and it does not work properly, again, we cannot get the oxygen out to the cells of the body. So we know the brain and all the cells of the body really need this supply of oxygen in order to continue to function. And hypoxia is that term that we use when we say low level of oxygen function. So hypo being low, oxia being oxygen, going back to your med term. Hypercapnia is the term that's used when we have high levels of carbon dioxide. Hyper high, capnia, carbon dioxide. So when we're looking at these things with the body, we may have both conditions. We may have one or the other. It just depends on what the patient is experiencing. So assess the cardiopulmonary system by listening to air movement, by checking a pulse. We want to make sure that the patient is receiving extra oxygen if they need it, but in the same, we want to make sure that they are able to offload the carbon dioxide that the body's been producing. So the body has to maintain homeostasis, and homeostasis is the balance that we need to work efficiently. And this is going to be chemoreceptor based, in that the chemoreceptors are typically detecting the level of carbon dioxide within the body. By detecting the amount of carbon dioxide in the body, it's going to then tell the brain, hey, our respiratory rate should be this, our heart rate should be this, and that's going to help to get the air in and hopefully circulate it. It also is going to send the signal of what the blood vessels should do as far as dilate or constrict to increase blood pressure, to ensure that that blood gets to all of the cells of the body. So if we have a patient who is in some type of cardiopulmonary issue, we kind of break them into two terms. So respiratory distress tells me that your compensation mechanisms are working. So the patient has a normal mental status, their skin color looks okay, their pulse oximetry reading is okay, but we've noticed that maybe their respiratory rate has increased and or maybe their heart rate has increased. Now when we get to respiratory failure, we're dealing with inadequate breathing and our compensatory mechanisms are not working. This means our heart rate's probably increased, our respiratory rate has probably increased, but we are noticing some changes in the skin color, mental status, or pulse oximetry readings because the body's no longer able to kind of juggle things to cover up or to compensate for the issues that it's experiencing. Respiratory failure is a precursor to respiratory arrest, and respiratory arrest is going to be when the respiratory system completely fails and or stops. So remember, breathing involves a couple of things. So when we're looking at is this adequate or inadequate breathing, let's look at the rate of breathing. Let's look at the depth of their breathing. Are we seeing equal rise and fall of the chest? Does it appear to be adequate rise and fall of the chest? And both, are we looking at normal ranges or abnormal ranges? Recognition is going to require assessment and prompt action if we find a problem with this. The sooner we react and intervene for these patients, usually the better outcome they're going to have. So yes, remember part of our ABCs, we want to see, is the patient breathing at all? And if they are breathing, is it adequate? Signs of adequate breathing, again, equal expansion of the chest, rise and fall. We can hear air entering, leaving the nose, the mouth. The air can be felt leaving the nose and the mouth. The skin is normal color. And then when we talk about our respiratory rate, we've got a normal rate. We've got a normal depth. The rhythm is regular with our respirations, not sporadic. And quality, again, we're hearing that air move and it sounds clear with no abnormal lung sounds. So that's normal. What's abnormal? Inadequate breathing. We may see mental status changes. Your patient may be confused. They may seem kind of foggy or slow to comprehend and process your questions. They may be completely unresponsive. Chest wall movement may be absent. We may see very shallow respirations, or we may see what we call irregular rise and fall or paradoxical motion, and that's just irregular movement of the chest, maybe only right-sided chest movement. Maybe we see an unstable segment of the chest where we've got irregular movement with respirations. The pulse rate is slow in children or slower than anticipated. Remember, we've got normals for our vital signs across the age spectrum. Breathing movements are limited to the abdomen, which tells me that we don't have good expansion of the chest. If we do not hear or feel air moving in and out of the nose and mouth, breath sounds may be diminished, they may be absent. We may hear those adventitious lung sounds such as wheezing, crowing, the upper airway obstructions such as stridor, gurgling, or even gasping are all indicators that there is a problem. So some other signs of inadequate breathing are going to be the rate of their breathing, being too fast or too slow. We have that normal parameter that our respiratory rate should stay within. Breathing may be shallow or deep, or maybe labored. We see some intercostal retractions. We see the patient is struggling to get air in and out. Cyanosis of the skin. A lot of times we'll see this first around the lips or the tongue. We call that circumoral cyanosis. We might see a delayed capillary refill of the nail beds. Inspiration or expiration may be prolonged. Your patient may be unable to speak or may only be able to say 2 or 3 words at a time without trying to take a breath in between. Again, those retractions, nasal flaring, signs that they are struggling. We primarily see this in children. If our pulse oximetry reading is less than 95%, or the body position that the patient is in. Patients who are in respiratory distress, they typically do not like to lay down. It's harder to breathe. Many of these patients will sit up and sit forward in what we call a tripod position. This allows for the chest to expand more fully. So we know hypoxia or lack of oxygen is a concern. When do we think this is going to happen, or when should we be really paying attention to this? Well, if a patient is trapped in a fire, there's less oxygen. If the patient has a condition called emphysema or COPD, then they're going to have issues with retention of carbon dioxide, which means we've got less area for that oxygen to go through gas exchange. If the patient uses certain medications or overdoses on medication, some of these medications can actually depress the respiratory system, causing their respiratory rate to decrease, causing their depth of respiration to decrease. And if a patient has a problem, such as a heart attack, a stroke, or an embolism, these also will cause issues with their level of oxygen. Look for those signs that we discussed earlier, including cyanosis or altered mental status, to determine if your patient is having hypoxia. If we can determine what the cause of the hypoxia is, let's try to fix it. But we can also administer oxygen to try to counteract that hypoxia if it's a condition we cannot fix or we cannot manage in the field. again, the sooner we intervene, the better outcome our patient is likely to have. And if we have a patient who is not breathing or has inadequate breathing, then we need to assist them with breathing, and that's done through our artificial ventilation with our bag valve mask. We can supply supplemental oxygen to a patient who is breathing but may be experiencing some hypoxia by using different oxygen delivery devices. And again, intervene as soon as you can. We want to meet the patient's physical needs, and if we don't do something, it's likely that they will continue to deteriorate from that point of respiratory distress to respiratory failure and potentially respiratory arrest. Think about all of the tools that you have that can assist these individuals and use your critical thinking skills to decide what is the best treatment option for this patient. Remember, if we get a little too aggressive, then okay, the patient is going to be better. We can always back off a little bit. If we don't do enough, we're going to continue to see the patient deteriorate. So positive pressure ventilations, this is artificial ventilations. This is something that we did when you learned CPR. And this is us using positive pressure to force air into the lungs. We can do this when the patient has stopped breathing or has inadequate breathing. Positive pressure relies on a force, and that force is us squeezing the bag. This force overcomes the force within the lungs, within the chest, and pushes that air in. When using positive pressure, we need to make sure that we are using it appropriately. Cardiac output and blood pressure can sometimes drop because the heart's ability to refill has also been affected. If we are not ventilating the patient properly by squeezing the bag too hard or too fast, we can have issues such as gastric distension, where the air is actually going into the esophagus and down into the stomach instead of the trachea to the lungs. And hyperventilation, or squeezing too fast again, will blow off too much carbon dioxide. This can lead to issues with vasoconstriction and hypocapnia. And again, remember, our body needs this balance. We need to maintain homeostasis, which means we do have so much oxygen and so much carbon dioxide in our body at any given time. When we are talking about positive pressure ventilations, there are a couple different ways that we can do that. One is mouth to mask. This has to be a specialized mask with a filtration system where you are going to put your mouth over it, hold that mask securely, and provide those ventilations. We don't see this as much in the field for us because we have bag valve masks. You may see these mouth to mask devices in the lay public. People carry these sometimes in case an individual needs CPR out in the general public. When we're dealing with our bag valve mask, we have one person and two person bag valve mask maneuvers. These were again taught to you in CPR, but remember, if we are the only person there providing ventilations, we need to make sure that we have a good seal on the mask and that we are squeezing that bag low and slow. If we have a two rescuer bag valve mask, one individual is typically holding the mask down, creating that seal, and the other rescuer is squeezing the bag. Never ventilate a patient who is vomiting or who has vomit in their airway. Remember, we need to suction them really well before we try to provide ventilations to remove that debris and prevent it from going into the lungs. As we are providing these ventilations to the patient, make sure you are identifying rise and fall of the chest. Remember, we want to see equal rise and fall of the chest. If not, that could indicate another problem. and be sure that we are maintaining the rate of ventilation. If you recall, our rate of ventilation in rescue breathing is 1 breath every 6 seconds. Inadequate ventilations occur when we don't get rise and fall of the chest, if the air is leaking from around the mask, or if we are ventilating the patient too fast or too slow. This is a process that we are going to continue, and it's not just one breath we're watching, it's every breath, that continued reassessment. The technique should always ensure adequate protection from the patient's bodily fluids. Remember, we want to make sure that we are not using mouth-to-mouth ventilation. If we are using mouth-to-mask, we have to have the appropriate barrier device in order to do that. If we are using our bag valve mask, remember we need to have our gloves on. We may want to have face protection on in case the patient does vomit, and we need to have our suction readily available. When ventilating a patient who is breathing too rapid, or we might say a patient who is hyperventilating, we need to help them to settle down. Sometimes we can talk to the patient and have them control their breathing or try to coach their breathing. Typically in this situation, we want to tell the patient to slow their breathing and take shallow breaths. This is because they have been blowing off too much carbon dioxide and they've been inhaling too much oxygen, so they kind of get that tingly feeling. These individuals need to slow their breathing to reduce the amount of oxygen, but also have shallow breathing so that they are retaining some of that carbon dioxide, again, to even things out. We want to explain to the patient what we're going to do, however, if we are going to use a bag valve mask to assist their breathing. The mask is going to be placed over their mouth and nose. We're going to create that seal, and we are going to squeeze the bag with the patient's inhalation. Now, as we do this, we're going to try to adjust their respiratory rate over the next several breaths to get them to breathe more slowly. This may be difficult for patients to tolerate, especially if they are claustrophobic or they may feel like they cannot breathe. So be careful with doing this, and again, talk to your patient, explain what you are doing and why. Same really goes for that patient who is breathing too slowly. If they're breathing slowly, we need to get that oxygen into their bodies. We want that carbon dioxide to offload. We need to explain what we're going to do to the patient, apply the mask, getting a good seal, and then begin those ventilations. This is going to be ventilating in between the patient's ventilations, and we are going to try to get them to a rate of about 12 breaths per minute. We have discussed before the importance of making sure that the airway is clear, and in order to open that airway, we might need to clear any secretions or vomit, any foreign objects that might be in the airway. We can do that with suction. We also want to make sure that the patient is in adequate alignment so that they have an open airway. We prefer that sniffing position. Again, remember, we need to ensure that the patient does not have a cervical spine injury when trying to open the airway. We typically want to elevate the head slightly and extend the neck. Remember, the earlobes should be at the level of the suprasternal notch. Adjust padding based on the patient's anatomy, and if we have children, especially younger infants, it may be supporting the back or just between the shoulder blades and providing that padding there so that we can create that level anatomy. Opening the airway can be a little more difficult in those obese patients. So when you have someone who is quite large, you've got a lot of neck tissue, neck folds, and subcutaneous fat, it may be beneficial to put the patient in what we call a ramp position, where the torso is at about a 45-degree angle and the head is flattened. so that you have the earlobe level with the suprasternal notch, but you have the patient's face facing the ceiling. This again will help to open that airway, alleviating pressure from all of the subcutaneous fat. Ventilate supine injury patients with their head in that neutral position. Remember, if we have a suspected spinal injury, we need to ensure that we are maintaining C-spine to prevent further injury if at all possible. Getting a proper seal on the mask is going to be vital in trying to provide positive pressure ventilations to any patient. The mask should fit well from the bridge of the nose down to the cleft of the chin. It should not cover the eyes. It should not overlap the bottom of the chin. It needs to be wide enough to cover the entire mouth, and if we are doing one rescuer positive pressure ventilations, then we are going to use the EC technique to try to secure that mask. We are going to need our other hand to squeeze the bag. If we have two rescuer bag valve ventilations or positive pressure ventilations, one person can use both hands to establish that seal while the other medic is squeezing the bag. And of course, there are always some issues that we can run into with sealing that mask. Patients may have certain physical features that cause problems with getting a good seal. One of these may be large or bushy beards or facial hair. Sometimes if we get this hair wet, we'll be able to create a better seal. Also, individuals with dentures. The dentures help to provide structure to the face. They allow us to get a better seal because of that structure. However, if the dentures are ill-fitting or are loose and become dislodged, you need to remove them. There are a few things that will help us to get a better seal and provide better ventilation to your patient, and that is rising the head to about 30 degrees, using an airway adjunct such as your OPA or NPA, and by using two-person positive pressure ventilation techniques. I mentioned this before with the mouth-to-mask ventilation, and I want you to understand that these are typically made of soft collapsible plastic. They do have infection control features, being a filter to protect you from any contaminant from the patient. They may have an oxygen inlet where you can actually attach a supplemental oxygen to them. They're usually made of a clear plastic so that you can visualize the patient's mouth and nose, and they may have a strap to put around the patient's head to help kind of keep them in place. However, you're still going to need to create that seal with the mask and provide adequate pressure with your ventilation. On page 257, you can see some of the pocket masks and the use of a pocket mask as well. When performing the mouth-to-mask ventilations, you should be positioned at the top of the patient's head. Usually, the EMS provider that is at the top of the patient's head is in charge of the airway and most often the ventilations too. Put yourself directly above the patient's head and place the patient's head slightly elevated in the sniffing position. Here we can apply the mask, and we have good access to secure the mask, create that seal with our thumbs and index finger, and then we can also help to lift the jaw slightly with that jaw thrust maneuver to open the airway. As we lift the jaw with our fingertips, again on the angle of the jaw there, we are going to depress our thumbs down into the mask, creating that seal, and we're going to give our breaths through the valve that is supplied. The steps for mouth to mask ventilation is on table 10.3 of your textbook on page 258. So the previous steps will work with a patient with or without a spinal cord injury. However, if we know the patient does not have a spinal cord injury, we can be a little more manipulative with the airway. So at this point, we can position ourselves besides the patient's head. We can again use that sniffing position, applying our mask. Here we can use our index finger and thumb towards the top of the head along with the top border of the mask, creating that seal. Your textbook states to place a thumb of the hand towards the feet on the lower margin of the mask and the fingers along the jaw. This allows you to help lift the jaw with the head tilt chin lift maneuver while you compress the mask to the face, creating a shield, and you may be able to give your breaths this way. I will tell you that for an individual with or without a spinal cord injury, my preference is to be at the head of the patient. It really does not matter the body position that you're in, as long as you're able to deliver those breaths effectively. Again, these are your techniques for potential spinal cord injury and positioning yourself at the head of the patient. Remember, with a patient with a potential spinal cord injury, we do not want to manipulate the neck. The patient needs to be maintained with C-spine motion restriction, and we're going to lift the jaw using the jaw thrust maneuver. So we're going to use the bag valve mask anytime we need to ventilate non-breathing patients. The bag valve mask is a tool that you will most often see on our ambulances, unlike the mask-to-mouth devices. So it's important to remember these bag valve masks come in a variety of sizes. Not only do we have different sized masks, we also have different sized bags. These do provide infection control because we are not that up close and personal with the patients. And with this, these bags are self-inflating or self-refilling. They usually have a no-jam valve, and this allows us to hook up supplemental oxygen to the backside of that bag and then provide that with each ventilation. Here you can actually see the different sized bag valve masks. These come in, again, adult, child, and infant sizes. You can see each has a different sized mask, and all of them have a reservoir bag and tubing in which you can connect to supplemental oxygen. So when you look at this bag, understand each part of it is a working part and designed for a reason. So we have an oxygen inlet. This is attached and enters the reservoir. And that way when we squeeze the bag, we're able to deliver that extra supply of oxygen. So we're supplying a higher concentration than the normal 21% from room air. When we squeeze the bag, the air inlet closes. This allows us to divert the air only to the patient, and it doesn't backflow. When we release the bag, the patient passively expires or breathes out, and the bag will reinflate on its own. As the patient exhales, oxygen enters the reservoir again, and the bag is ready for the next squeeze. Remember, every patient is going to have their own unique situation, and so care may have to be adjusted slightly for each individual. But when we're supplying positive pressure ventilations, there are a couple of things we just need to keep in mind. One of them is suspected C-spine trauma, and the other is going to be how many rescuers do we have available to assist us with this. So if we do not suspect any trauma, then we can put the patient with their head elevated in that sniffing position. We can get the correct bag valve mask sign, size, so the mask and the bag are appropriate for this patient. Kneel at the patient's head. Position your thumbs along the sides of the mask and depress the mask downward, while we use our fingers at the angle of the jaw to lift slightly to assist in opening the airway. Remember, the point of the mask needs to be resting on the bridge of the nose, and then the mask will be lowered over the mouth and chin. Be sure that it fits appropriately. Once the first rescuer has the mask in place and the seal is created, the second rescuer can then squeeze the bag low and slow. This should take place over 1 second, and we really only squeeze the bag about halfway. We're looking for rise and fall of the chest. We don't need to hyperextend the chest. The second rescuer then will release the bag and let the patient exhale. If we do suspect a spinal cord injury, we've got to be a little more careful with maintaining that neutral position and not manipulating the cervical spine. With this, again, we want to have the correct size of BVM. We want to kneel at the patient's head, positioning our thumbs along the sides of the mask, pressing it downward while lifting up on the angle of the jaw. The second rescuer is going to squeeze the bag, as we stated before. This is a good image of your two rescuer positive pressure ventilation technique. You can see this on page 261 of your text, and again, read about it further in Appendix 1. Depending on the situation, the other rescuer may have other tasks to do. So one rescuer may be providing the bag valve ventilations while the other rescuer has other interventions that they are going to do. So this one rescuer needs to place the patient in a head elevated sniffing position, again, if we are not concerned with a C-spine injury. Choose the correct size mask and bag for the patient. These one rescuers will be not only securing the mask, but also needing to squeeze the bag. So we're going to use one hand to form a C around the ventilation port with the thumb and index finger. The index finger will be on the chin of the mask, the thumb up on the bridge of the nose of the mask, and then we are going to use our other three fingers, middle ring and pinky finger, to hold the jaw. Sometimes we call this the EC technique because your pinky ring and middle finger kind of form an E on the patient's mandible, and your index finger and thumb form a C on the mask. Once we have the seal established, we can squeeze the bag with our other hand and then release the pressure on the bag to allow the patient to exhale. I will tell you that whichever hand you want to use to create the seal and then squeeze the bag, it doesn't matter if you are right or left-handed because the bag can swivel. As long as you're creating that seal and you have an adequate squeeze of the bag, that is our primary goal. Well, what if we don't see rise and fall of the chest when we squeeze the bag? We need to kind of troubleshoot here. So let's reposition the head. Let's make sure that the airway is open. Make sure that the tongue is not on the back of the throat. Maybe we want to use one of our adjuncts like an OPA or NPA here. We want to check for any escape of air around the mask. Maybe we did not get a good seal. And then we also want to check for any airway obstruction, maybe by a foreign object. Maybe we'll need to suction the patient. Definitely something that needs to be considered. If we do all of these things and we still cannot get the patients to have rise and fall of the chest with the ventilation, then we may need to look for an alternative method. Yes, of course, use your BVM during CPR. The bag is squeezed once every time a ventilation is to be delivered. Remember, We are doing 30 to 2 with our CPR. So we are going to do 30 compressions to 2 ventilations. If we do have a 1 rescuer CPR, and again, for us, that's not usually happening because we work as a team with other EMS professionals, but if we are a lone rescuer, then using a pocket mask or the mouth-to-mask is going to be easier because we don't have to manipulate the bag each and every time. A unique situation that you may come across is someone who has a stoma. And a stoma is an opening in the neck for the airway. There may be mucus in this stoma, and so we may need to suction the stoma to relieve those secretions from blocking the airway. We need to leave the patient's head and neck in a neutral position because we don't have to worry about the tongue creating that obstruction. We are going to ventilate this patient right over the stoma. If we don't have a direct connect for the stoma, we can use a pediatric-sized mask and we can create a seal on the neck just over the stoma and squeeze the bag as we would for normal ventilation. If we are unable to ventilate through the stoma, we may try to seal the stoma and attempt ventilation normally with the mouth and nose. The patient most likely will have a plug or something in order to seal the stoma. So look around the environment. Keep in mind we have a normal ventilation rate, and if we are providing positive pressure ventilations too fast or too slow, we can cause complications. If possible, one rescuer should focus on ventilation while the other focuses on maintaining that seal. Again, adults should be ventilated every 10 to 12 times per minute. Usually through our AHA CPR, we are instructed to ventilate 1 breath every 6 seconds. And in the event of CPR, remember it is 30 compressions with 2 breaths. Children should be ventilated at a rate of 12 to 20 times per minute. If you recall, your AHA CPR still states a ventilation every 6 seconds, or if we are doing CPR, 1 rescuer, 30 compressions to 2 breaths, and 2 rescuers are 15 compressions to 2 breaths. Remember also, it's not just about the rate in which we are ventilating, but also the amount of force that we are using to squeeze the bag. Too much pressure is going to cause the air to bypass the trachea and enter the esophagus, causing gastric distension. This may lead to the patient vomiting. Too much volume can cause the lung tissue to have trauma. So again, it's usually about a half a squeeze of that bag to 3/4 of a squeeze, and we're just looking for rise and fall of the chest. Pressure needs to be slow and gentle. One hand is used to squeeze the bag. If we are ventilating an infant or a child, the bag is going to be smaller, so we don't necessarily need to use the whole hand, but 2 or 3 fingers may work. Ventilations are to be delivered over 1 second, again, low and slow. Look for chest rise. We are not looking for full expansion, but movement of the chest is, again, the goal. There are some additional tools that might be helpful. One of them is an automatic transport ventilator, or ATV. This allows positive pressure ventilations to be given during a respiratory arrest without the individual EMS professional providing each squeeze of the bag. This machine has settings for rate and volume. It is portable. And again, if we have a long transport, if we're going to be ventilating this patient for a long period of time, this device really does give us almost an extra set of hands. However, the provider that is doing it must be sure to continually to monitor the machine and the patient and make sure that everything is working appropriately. This is an example of an ATV. You can take a closer look at this in your book on page 264, but you can identify it is going to provide you with the volume, it's going to allow you to choose the respiratory rate and make those adjustments based off of your patient. Let's talk a little bit about oxygen. So oxygen is a drug. It is one of those treatments that can substantially improve our patient's condition. But we have to know when it's appropriate to use it because it can cause harm. If we are using it inappropriately, too much, too little, we're giving it to patients that should not be receiving it, then that's going to create problems. Every patient is unique. We need to think about their underlying conditions. We need to think about the cause for their need for oxygen, and then with that, determine what's best practice in order to manage their condition. Cardiac patients always get ventilations if needed because we need to be sure that the heart is getting adequate oxygen. So we use oxygen quite often in EMS, and we have to make sure that it is safe, that it is easily portable, and that it's going to work when we need it to work. We do have oxygen setups inside the ambulance, either on the wall or the ceiling many times, but we also have portable oxygen cylinders that we can take into someone's home or take to the patient before we get the patient to our ambulance. These devices include a cylinder, which holds the oxygen, a pressure regulator that allows us to adjust the settings, and then some type of delivery device. And we're going to talk about those delivery devices such as a non-rebreather and a nasal cannula and how we can actually get that oxygen to the patient. Other devices like BVMs and pocket masks can also be hooked up to this oxygen if needed. Maybe you've seen these oxygen cylinders before. They are usually stainless steel in color and maybe have a green top on them. They may be completely painted green. They do come in different sizes, D cylinder, E cylinder. Just to give you some ideas, the D and E cylinders are your smaller cylinders that we find in our portable airway bags. The really large cylinders are usually found in an outdoor cabinet of your ambulance, in which then the tubing and stuff has been run to the internal setup. Again, they are green or green and white, green and silver in color, and they are seamless canisters. Understand these cylinders or these canisters are under pressure and they can explode, and we need to be careful when transporting them not to drop them or bang them around for fear of possible penetration of that cylinder. This image kind of shows you how that larger oxygen cylinder will be positioned in one of your outside ambulance compartments. You can see it is secured in there with straps so that it again does not bounce around during transport. So with these cylinders, make sure that all of our devices are working appropriately. We've got our pressure gauges, our regulators, we've got the tubing, any oxygen adjuncts that we're going to be using. Always use non-ferrous wrenches or non-iron wrenches. These have to be turned on and turned off sometimes, depending on how your service carries them. Usually the portable canisters are turned off each time so that there is no leaking of the compressed air. Always ensure that the valve seat inserts and the gaskets are in good condition, or you will have leaking air. Use your medical grade oxygen only. Always open the valve fully and then close it a half turn to prevent someone from trying to force the valve in any one direction. These cylinders should be stored in a cool ventilated room, properly secured in place. It's likely that the service will have extra cylinders for when one of them becomes empty. It can be replaced by the EMS team. Always have oxygen cylinders hydrostatically tested every 5 years. We need to make sure that they are still in working order. Never drop a cylinder or let it fall. Never leave an oxygen cylinder standing in an upright position without being secured. And never allow smoking around any oxygen equipment that is in use. Yes, oxygen is flammable and we need to be careful around open flames. We do not use any grease, oil, or soaps on the cylinders. We don't use adhesive tapes on the cylinders. They are color-coded for a reason, to identify what gas is inside that cylinder. And we never want to drag a cylinder or roll it. It's important to note that when these cylinders are full, they are quite heavy with that compressed gas inside. They do lighten over time as that compressed gas has been used. Take a look at the cylinders that you may have access to. They need to have safe working pressures of 30 to 70 psi, pressure per square inch. On cylinders E or smaller, the regulator is secured by using what we call a yoke assembly, and on larger cylinders we use a threaded outlet. Before connecting a regulator to a cylinder, make sure you open the main valve slightly to get any dust or debris that has kind of settled over that valve out. All cylinders will have a flow meter, which allows you to control the liters per minute that is going to flow through them. There are two types of low pressure flow meters. These are pressure compensated flow meters. These are on larger cylinders. And then our constant flow selector valves. These are on any cylinder. Your high pressure flow meters may be necessary for oxygen powered devices or respirators and ventilators. High pressure flow meters are not necessary for BVMs. These are a couple of images of flow meters that you may see. The image on the left is more comparable to ones that you might see in the hospital on the wall, or you may see them in your ambulance on the wall. And the little silver dial in the front allows you to regulate the oxygen that is being supplied through the tubing. You will see a little metal ball that will float up to the desired level, in which then you can just leave the flow setting there. The image on the right shows another device where you connect to your tank, and you see the dial to tell us how much pressure or how much oxygen is still in the tank. On the far right there you will see a black dial. That dial is to control the amount of oxygen that is being delivered. Again, if we're using a high pressure flow meter, this one shows that there is a threaded hose attachment here. Again, it does have a dial on it as well. You can see the 0 on the right side of that device, and that can be adjusted to increase the flow. Humidifiers can be connected to the flow meters, and this is just a special device that we attach to the oxygen delivery output, and then we attach our oxygen tubing for our oxygen delivery device to that. This allows the air to be humidified before the patient breathes it in. It's usually a non-breakable jar of water, and the air will bubble through it. It needs to be kept clean. There's a new bottle of water for every patient, And again, this is usually a plastic bottle that you will see. Many times you'll see this used most often in a hospital setting. Humidifiers are not often used in EMS because our transports are short. This is an image showing that humidified air. So you've got your dial, and the bottle of water is going to be connected straight to that regulator. And then there's an extra port then on your humidifier device that allows you to attach your oxygen tubing. So non-medical hazards are rare but can occur. This is oxygen, and this gas is flammable. We've got to be careful because these tanks are under a great deal of pressure. So should the cylinder be punctured, it can become a missile, it can explode, it can burn in a fire, or again explode in a fire. And oxygen under pressure and oil can create a severe explosion reaction as well. So we've got to take care of these cylinders. And remember, oxygen is a drug. So oxygen toxicity can occur, and we can overload a patient with oxygen. Remember, we need to maintain homeostasis and the balance of oxygen and carbon dioxide. Eye damage can occur to infants, especially premature infants, if they are receiving oxygen over long periods of time. Respiratory depression or respiratory arrest can sometimes occur because patients with COPD do not breathe based off of the level of carbon dioxide because those chemoreceptors have been damaged. So there are other chemoreceptors that will take over, but these chemoreceptors breathe based off of the concentration of oxygen. And again, this is why supplying oxygen to a patient that is a COPD emphysema type patient can actually be detrimental. Underlying conditions can be exacerbated as well as myocardial infarctions or strokes. So we've got to be careful. Again, be sure that we are using these oxygen delivery devices and providing oxygen to patients who need it. Oxygen can be delivered to our patients in a variety of ways. It's important that you understand each of these oxygen delivery adjuncts and when it's appropriate to use them. We will have some examples in the classroom, but you can also find information of these in your textbook. There are different reasons why we may need to supply oxygen to a patient. By looking at our patient and with our assessment, we're likely to see signs of shortness of breath, hypoxia, or we may actually have a low oxygen saturation on our pulse oximetry. Keep in mind there are different delivery devices. So for mild distress, we want to supply a lower concentration of oxygen, and this is usually with a nasal cannula. A nasal cannula is easy to use. We can deliver between 1 and 6 liters per minute of oxygen, and this supplies between 24 and 44% concentration. Remember, room air is 21%, so we're just giving them a little bit. For moderate or severe distress, we're likely to need a higher concentration of oxygen. Most often, we're going to give this with a non-rebreather mask. Non-rebreather masks are unique because they actually fit over the patient's mouth and nose, and they have a large plastic reservoir bag on them to help with delivering a higher concentration. These need to be set at 12 to 15 liters per minute. If we are not setting them at least that high, then we can actually cause hypoxia or worsening of our patient's condition. The idea is that we're going to supply the patient with between 80 and 90% pure oxygen. So again, this is for someone in moderate or severe distress. Be sure that you know your local protocols and know how to utilize the equipment that you have. The non-rebreathers are pretty easy to use, but again, you want to be sure that that reservoir bag inflates and your nasal cannula needs to be applied appropriately. The prongs should face kind of down and in towards the patient's nose, and if they don't have it in their nose, then it's not going to be effective. It's not going to be delivering the oxygen that we need. Believe me, I've seen patients hold it in their mouth. The non-rebreather mask also needs to be applied appropriately in order for it to deliver the oxygen we desire. So this is for high concentrations of oxygen. It needs to fit on the patient's face appropriately, again with the point being on the nose. Many of these have a little metal bar that you can kind of manipulate or fit to the patient's face a little bit better. They have a strap that will wrap around the patient's head, again to help secure them in place. We have to inflate the reservoir bag before putting it on the patient's face. This reservoir bag fills with that higher concentration of oxygen from our tank, allowing us to deliver that higher concentration to the patient. The reservoir must always contain enough oxygen so that it does not deflate by more than 1/3. Again, this is why we need to have our oxygen setting at 12 to 15 liters per minute. If you look closely at the non-rebreather mask, you will see a little flutter valve on the side. This flutter valve is so that when the patient exhales, the air can escape through it. However, the little valve compresses against the mask so that outside air doesn't get sucked in too much. We're really drawing that inhalation of air from the reservoir bag. A safety feature is an emergency port that enables the patient to receive atmospheric air if the oxygen fails. Again, this does not have that flutter valve on it, and so if we don't have the setting up high enough, the reservoir bag is not filling. We're not really going to suffocate the patient, but we're not going to be delivering the concentration of oxygen that we want either. Non-rebreather masks should be used on patients with hypoxia, shortness of breath, chest pain, or any concerns of altered mental status where we feel that hypoxia is an issue. Here you can see a patient with the non-rebreather mask on. You can see it fits on the bridge of the nose. It does come over their chin, unlike the bag valve mask. Here you can see the little white discs. Those are your flutter valves on the side. The strap is around the patient's head, and you can see the reservoir bag is filled with oxygen. Another look at that non-rebreather mask, not on the patient. Now again, our nasal cannula is a little bit different. This is where the oxygen is going to be delivered through nasal prongs. Again, these need to be pointing in and down as you put them on the patient. You can then extend that tubing around their ears, and there's usually a little slider clamp that you can then secure kind of under their chin so that they have a good secure fit with that nasal cannula. Oxygen is delivered through this between 4 and 6 liters per minute. Yes, sometimes you will see them down to 2 liters, just depends on the patient, but really these nasal prongs are quite small, and so if you tried to crank it up over 6 liters, the openings are not large enough to actually deliver that amount of oxygen. So there's no point in exceeding 6 liters. The cannula is the best choice for the majority of patients if they just need a little bit of oxygen or a little bit of support. Patients who refuse to wear a mask or a non-rebreather should be given a nasal cannula. Nasal cannulas are not uncomfortable, they're not painful, they don't make the patient feel claustrophobic like some of the non-rebreather masks may. But again, they have to wear it appropriately for it to deliver the oxygen intended. The partial rebreather mask is similar to a non-rebreather. It has the reservoir, but it does not have the one-way valve like the non-rebreather. So it's going to have your reservoir bag, and this is going to allow the patient to rebreathe some of their exhaled air. So if you think about it, they're not going to be receiving as high a concentration as with the non-rebreather, but the partial rebreather delivers between 40 and 60% oxygen and should be set at 9 to 10 liters per minute, again ensuring that that reservoir bag is full. The Venturi mask is a little bit different in that it does not have a reservoir bag on it. There is a picture of a Venturi mask on page 277 of your textbook. There's one coming up here too in the slides, but understand some of them do look different because many of them have different tips that can either be applied or can be adjusted to manipulate the concentration of oxygen that you're delivering to the patient. This is going to be important in our COPD patients where we really have to be careful at how much supplemental oxygen we are providing them. In your COPD patients, you will learn too much oxygen can actually cause their respiratory drive to decrease or stop. This is an image of the Venturi mask on a patient. You can see that the mask itself looks very similar to the other masks with our partial rebreather and our non-rebreather. It has that metal clip. It secures itself under the chin with one strap. And then the blue corrugated tubing here, you can see, again, some of these are going to look slightly different based off the brand that you have, but they do allow you to make more adjustments to the amount of oxygen the patient is receiving. And this is just an image of the Venturi mask not attached to the patient. Remember, if we have a patient with a stoma, this is a tracheostomy, a hole in their neck, we've got to be able to provide that supplemental oxygen through the stoma. It's usually a special mask that we use, and it is kind of a cup-like mask. You can see an image of it on page 278. It also shows it on a patient here. This can be connected to 8 to 10 liters per minute of oxygen, and if we do not have this specialty mask, you can use an infant mask as well in order to supply oxygen to the stoma or tracheostomy. And this is the same picture that is in your textbook on 278 of the tracheostomy mask. It is important to note that children and infants have a higher respiratory rate. They will crash very quickly, and so we've got to always be on the lookout for respiratory distress. If we have any child or infant who is showing us signs of respiratory distress, signs of inadequate breathing, or in shock, we need to supply them with high concentration oxygen. And I will tell you that's most likely going to be with a non-rebreather. However, sometimes nasal cannulas are difficult to keep on younger children. If we don't need to give them high flow oxygen, we may be able to just hold the tube near their face, and this allows the oxygen to pass over their face, and then as they inhale, they are breathing in that increased concentration of oxygen. Remember, each patient may present with some unique challenges. Individuals with facial injuries that require supplemental oxygen, we may run into some issues with bleeding. If they have a lot of bleeding and we've got to keep that airway clear, suctioning may be something that we have to do frequently. An airway adjunct such as an NPA, an OPA, or a King airway may be needed. If we cannot maintain that airway and we have paramedics or intermediates available to us, an endotracheal tube may be inserted. Obstructions, again by blood, but other objects may be the cause for some concern when trying to deliver oxygen to these patients. So we need to make sure that we have our suction available. If we have a complete obstruction, we may need to do the Heimlich or abdominal thrust maneuver. We may need to do some chest thrusts, or if we see the object and we feel we can get it, we can do a finger sweep. There are specialized instruments that we carry in our ambulance to also assist in removing these foreign objects. There's a long set of what looks like almost grabbers or tongs. They are called McGill forceps, and they are long and curved, and they can get back into the back of the pharynx area and grab objects if that is possible. Dental appliances may be good or may be bad. If they are properly fitting dentures and they are secure in place, we're going to leave them there. However, if they are loose, if they are ill-fitting, if they have partial dentures that we are concerned with coming dislodged at any point during our care of the patient, then we need to get those things out of the way. We don't want any new airway obstructions to occur while we're taking care of this patient if we can avoid it. We've mentioned before that infants and children can have their own problems, and when we talk about infants and children, one of the things that we need to consider is the anatomic differences. So we know that the tongue is larger, it takes up more space, it can also obstruct the airway of these little ones. The trachea is softer and more flexible. We've got to be sure that the trachea is intact and that there's nothing applying any pressure to the trachea. The head is disproportionately larger, and we know that trying to keep the airway open may be more of a challenge. Putting padding behind the shoulder blades may assist in maintaining an open airway for these little children. The chest wall is softer, and we may see abdominal breathing, we may see intercostal retractions, we may see nasal flaring. These are all signs of increased respiratory distress. And then with infants and children, the oxygen burn rate, or their metabolism of oxygen, is twice that of an adult, which is why they have a faster respiratory rate and why they have a faster heart rate. So we've got to be able to keep up with the demand of their body. We know that the lungs of infants and children is smaller. This is why we have masks and bags of different sizes. We want to be sure that we have the correct size mask for the child that we're caring for, and we want to be sure that we are not using excessive pressure and volume when we use a bag valve mask to ventilate. Remember, we're looking for rise and fall of the chest. Flow-restricted or oxygen-powered ventilation devices are contraindicated in pediatric patients because of the concern for excessive pressure and volume. Use pediatric-sized non-rebreather masks or nasal cannulas, and if we can't use the appropriate size or if the child is not tolerating it, think about doing the blow-by technique where you just hold that oxygen tubing near their mouth and nose and allow them to breathe it in freely. Gastric distension can also impair adequate ventilations in infants and children. If we are using too much force when we are using our BVM and we are causing gastric distension, this is going to inhibit the lungs from fully expanding, therefore affecting the oxygenation of this patient. So if we happen to have a paramedic or a higher level EMS provider or medical provider that is going to intubate a patient, we may assist them in doing so. Now, we aren't going to be the ones passing the tube, but we can support them as they provide this treatment to the patient. So before the tube is placed, we may be asked to kind of pre-oxygenate the patient and give them some extra oxygen. The individual that is intubating the patient will position them as they see they need to in order to intubate the patient. They will remove any oral airway that maybe has been inserted to maintain the airway, because the endotracheal tube is going to go there and secure the airway more appropriately. We may be asked to help with the burp maneuver. The burp maneuver is backwards, upwards, rightward pressure that is applied to the cricoid cartilage. You can see an image of this on page 282, and we've got a picture coming up on the next slide as well. But by manipulating the cricoid cartilage, we manipulate the trachea, and that allows the vocal cords to come into better view when the provider is using the laryngoscope to insert that endotracheal tube. Please understand, these endotracheal tubes are used only on patients who have no gag reflex and are unconscious. You can see the laryngoscope in the left hand of the EMS provider here. You can see the light so that the cords can be visualized, and in the right hand you can see the endotracheal tube that is being passed through the cords. The blue gloved hand on the neck of the patient is providing this burp maneuver, backward, upward, rightward pressure. As the advanced provider places the endotracheal tube, then we need to ensure that the tube is in the proper place. We do this using two methods. The provider should have visualized the tube passing through the vocal cords. We then want to listen to lung sounds to ensure that we have equal lung sounds on both sides, the left and the right. We want to listen over the epigastrum or over the stomach to ensure that we do not hear airflow through the stomach with the ventilation or with the compression of the bag. The tube is then secured in place by a commercial restraint. This is usually a Velcro strap that goes around the patient's head, securing to the tube. We may be asked to monitor the lung and epigastric sounds to be sure that the tube does not become displaced during our transport. Once the tube is in place, we have to be sure not to manipulate it too much. Anytime the patient is moved, transferred from cot to cot, the risk of displacement is there, and so we've got to continually reassess to ensure that the tube is located in the main stem bronchus and is able to provide ventilation to both the left and right lung. So again, movement can displace the tube, so be very careful. Ventilate about 10 times per minute or every 6 seconds. Hold the tube against the patient's teeth with 2 fingers of one hand. Again, we want to be sure that we have that commercial device in place, kind of holding the tube at the proper depth, but we do need to hold the tube with our other hand that's not squeezing the bag, because we want to stabilize it. Use the bag with the other hand and squeeze to provide that ventilation. And if ventilating a breathing patient, allow timed ventilations with their respiratory effort as much as possible. This will help and try to prevent the patient from fighting your ventilations. With an intubated patient, ventilations should be easy. We should be able to easily squeeze that bag, and it should reinflate easily. However, if you feel you're meeting some resistance as you squeeze the bag, be sure you let that higher EMS provider know. This may be an indicator that there are additional problems taking place or that the tube has become dislodged. If the patient is going to be defibrillated, so we're going to shock the patient, we need to remove the bag from the tube and do not touch the patient. We don't want to leave the bag hanging on the tube for fear that it may cause some pressure changes and displace the tube. So just disconnecting it for that short amount of time during defibrillation is appropriate. Watch for any changes in the patient's mental status. If we are ventilating the patient and they become conscious, the tube may need to be removed. So notify that higher level of EMS professional so that they can reassess the situation. During cardiac arrest, you may be asked to remove the BVM so that medications can be injected. And I say this with great disdain because we don't like to put medications down an ET tube. However, in some situations, it will be done. So if medication is to be put down the ET tube, the bag will need to be disconnected from that ET tube, the medications will be pushed down, and then the bag can be reattached and then compressed in order to disperse that medication. Again, typically this is not done because the patient has an IV or intravenous route or an IO, intraosseous route, in order to provide medications. If the patient has a suspected C-spine injury, then stabilization of C-spine is going to be necessary. We want to use that spinal motion restriction by holding manual stabilization until a C-collar can be applied. You will then stabilize the head from the patient's side while the paramedic tries to adjust the patient with the laryngoscope in order to intubate them. After the patient has been intubated, you will hold the endotracheal tube in place. Once placement is confirmed, we need to note the depth of the endotracheal tube, and it needs to be anchored with one of those commercial devices. You must hold manual stabilization in addition to a collar until the head is taped onto the backboard, head blocks and Velcro straps are applied, whatever you need here, but we've got to make sure that we keep everything secure and from excessive movement. Remember, there's a difference between respiratory distress, respiratory failure, and respiratory arrest. Know when you need to intervene and what devices you have that might assist you in doing so. If a patient is breathing but breathing inadequately, bag valve mask ventilations may be necessary. Some things to watch for is inadequate breathing, of course, but what about skin color, skin temperature, skin condition? Does the patient appear to be short of breath? What are their complaints? Are they complaining of chest pain? Do they have any traumatic injuries, including injuries to the chest? What about their mental status? Are they alert? Are they confused? Are they unresponsive? Remember, you as the EMT, your safety comes first. So always be sure you have on the correct PPE or BSI. Assessment of breathing must be an ongoing process. We're going to continually reassess and reassess. Inadequate breathing requires immediate action. Be sure that you are delivering your positive pressure ventilations appropriately. Remember, there are some negative side effects that can occur. This can be done improperly and can cause further complications with the patient if done inappropriately. Make sure that you are selecting the most appropriate delivery method of positive pressure ventilations or supplemental oxygen for your patient. There are some safety concerns to remember when using oxygen or transporting cylinders. So think about the signs and symptoms that you will see with respiratory distress or respiratory failure. When we're doing bag valve mask ventilations or BVM ventilations, how do we do them with one rescuer or two? What techniques should we be aware of? Think about your positive pressure ventilations and your assessment if those ventilations are adequate. Think about problems in which we may encounter when trying to deliver this supplemental oxygen to the patient. How are we going to troubleshoot these things and correct them? So we have a female patient who is semi-conscious. So this means she's not fully alert. She might be kind of going in and out of consciousness, but she's definitely altered. Her respiratory rate is 7. She is pale, slightly blue or cyanotic around her lips, the circummoral cyanosis. Are you concerned? Would you agree this patient is in respiratory failure? What signs and symptoms really indicate that? And at this point, how are we going to care for this patient? What steps are you going to take in order to try to correct her condition? That's all for ventilation, so good luck moving on to the next chapter.